Very good afternoon to everyone, and thank you very much, Dr. Shah and Dr. Sangwan, to have me in this very, very interesting symposium on PUK. I'm so happy to see a full hall on such a rare subject. So, coming after such a beautiful talk by Dr. Dalia, my job is made partly simple also. So, I'm going to cover the immunopathogenesis and differential diagnosis, the question that was asked. So what is PUK? It's classically immune-mediated. That's what we've been hearing. It's a rare inflammatory condition involving the juxtalimbal corneal stroma, and probably you would heard Inisha's talk about the juxtalimbal corneal stroma. It can be either just the eye, or it can be associated with certain systemic immune-mediated disorders. There's a high association with connective tissue disorders. In fact, nearly 50% of classic PUK that we see, they could be associated either with RA, or with GPA, or even with PA and SLE, polyarthritis nodosa and SLE, which are much more rarer. And ocular manifestation can come before the systemic disease. In the etiology, I've tried to make it very simple so that we don't get bored. And then both the cell-mediated and a humoral immunity in conjunction with the corneal tissue destroying substances, which are those are the metalloproteises, the matrix metalloproteases. So all the immune systems are wired up and they start causing the inflammation. How does this happen? So we have the cell-mediated immunity, which upregulates the CD4 cells, and they are also dysregulating the autoantibodies. They activate the autoantibodies with the humoral immunity, which signals there's loss of the B cell tolerance to our own antigens. So the B cells think that this is a foreign antigen. The serum IgM start getting directed towards the natural IgGs. And in the case of certain diseases like RA, there are anti-CCP antibodies floating around. In GPA, there are ANC antibodies floating around. So all of these put together, they torture the cornea. So there is an upregulation of the matrix metalloproteases and downregulation of the TIMPs. So there's especially increase in the collagenase activity, there's increased tissue destruction and ulceration. And overall, there's a decrease in the tissue repair. So this is how all of this put together, they start attacking the bichara cornea, the periphery. So that's why I always feel very sad for the cornea. So, and also I think you must have mentioned in your talk is that the limbus seems to, that the limbal architecture is such that it seems to be a watershed zone for all sorts of inflammatory cells coming there. So the relevance, why is it, if those of you who are general ophthalmologists or seeing a lot of patients, and some of them will come in with PUK, what's the relevance? So the pure immune-mediated PUK like the GPA, RA, you may not see that much on a daily basis at least. The Murren's ulcer, though rare, but you might see these cases occasionally. The PUK-like lesions, as a question was asked, you will definitely see these PUK-like lesions, and I'm going to bring up those. And luckily, though the associations with, say, rheumatoid arthritis or granulomatosis polyangiitis is rare, but you should be able to recognize them and refer them, unless you're anyway going to treat these patients, in which case you must get confident to treat with systemic immunomodulators. So coming to so one way to look at the differential diagnosis would be to sort of classify PUK, which I do in my mind. I think of the local causes. So am I looking at a local infection? So the question asked was, could HSV? So am I thinking of a local infection versus is it going to be a systemic immune-mediated disorder, or even a local immune-mediated disorder? So under immune PUKs, pure immune PUKs, you can have the eye only or involving the body as well. The pure eye PUK is Murren's ulcer. So Murren's ulcer is nothing but a peripheral ulcerative keratitis in which the eye is the only organ that is involved. The eyes or the cornea is the only organ that is involved. So the slide at the bottom, whereas that is a case of bacterial keratitis with perforation. It is not PUK. The slide at the top is Murren's ulcer. So under the local causes, under infections, you can have even bacterial, fungal, viral, parasitic. Under non-infectious, something like trauma, or the lids and lashes. So I'll come to this in the mimickers of PUK. If they continuously keep rubbing a particular area, so if you're not very astute of it's not there all the time, a trichiatic eyelash going on rubbing the cornea, causing melting, some of us might think it's PUK. Under systemic causes, you can have immune-mediated, some dermatological conditions, and some systemic infections. This I've already covered. So under the non-infectious causes, to add on to complete the list, you can have traumatic, for example, peripheral corneal thinning in chemical, thermal, radiation, not during the acute phase, but as a healing. The eyelashes I had covered already, and about In viral, there are two mechanisms. One is the neurotrophic part and the second is an acute infection. So again, to complete the list, this is just for completion. So we have all the autoimmune vasculitic disorders on your left side and a few dermatological conditions I mentioned earlier, such as cicatricial pemphigoid and Stevens-Johnson syndrome, which can also lead to a PUK or a PUK-like picture. But the immune-mediated disorders are in the ones on your left side. So the list just goes on a little bit more, even inflammatory bowel disease and certain systemic infections. I talked about eye infections mimicking PUK, but even patients with systemic tuberculosis and certain other diseases can also have a PUK-like picture. So in other words, we can divide the classification as due to inflammation, our mimicking conditions due to degenerative, and those conditions which are due to the bystander, like there's a corneal infection or scleritis, and then there's PUK. Coming to the infectious causes, this is a classic example that somebody mentioned earlier. And what I think the keynote speaker may have left, but what we're trying to say is that when you have marginal keratitis, so these patients come in, if we don't recognize it fast enough, you know what happens in viral, that there is a very rapid melt of the peripheral cornea. And when the patients come to us, sometimes it looks like PUK. So the differential diagnosis, look for corneal sensations. In spite of this much inflammation, patient doesn't look like patient is very distressed. And then when you see the grayish infiltrate leading that edge of the ulcer, this does not happen in a classic PUK. This is another case which was actually referred as PUK, but this is actually bacterial keratitis. There's no way to know just looking at it. You need to go sequentially in the patient's history. The patient had acute infection, was on antibiotics. So there's no hypopion now, it's resolving. But bacteria, it proliferates very fast, causing a lot of destruction. And so the patient presented with a perforated corneal ulcer. Only thing, it was in the periphery and therefore labeled as PUK. The flip side can also happen. So on your right side, you have a slide which shows a very advanced PUK. Look at the hypopion. That is very unusual. So this patient had bacterial keratitis in advanced Moran's ulcer. That can happen because it can be a secondary infection. Sometimes, if you're not very careful, so look at the slide on your left and on your right. Same patient. So the left side shows a typical lack of corneal luster. And so this is a patient we're looking at keratoconjunctivitis sicca. So that patient doesn't really have PUK, but there is desiccation of the cornea because of lack of tear film, and it looks like it starts melting. When you start steroids, when you start lubricants intensely for this patient, you will see that the Dellin effect rapidly sort of becomes much, much better. So this is not PUK, no need of systemic workup. It is dry eye. Investigate, of course, for RA, but for a different reason. And this, when you apply stain to the right eye, you'll see the staining areas. Even in the conjunctiva, you can pick up stain. One more case of cause of dry eye. This is a patient with secondary Sjogren's, presents with perforated ulcer, you can call it, or a sterile ulcer, and that is not PUK again. Some other mimickers which come to us as resolved PUK, Terriens is a great mimicker for that, because this is very advanced Terriens. You'll see all the white lipid-like deposits over here. But if you have a patient with early Terriens or an inferior Terriens, which is very unusual, so the eye looks very quiet and the patient may have had some congestion, but not really very severely symptomatic. So this is a classical case. See on the slit how this area looks very thinned out in the periphery, but this is Terriens. You can do pentacam and you get the classic image for that. Sometimes even PMCD, peripheral marginal corneal dystrophy, can mimic PUK, because again the periphery over here is very thin. So not all thinning appearances are PUKs. And this was a rare case which similar to one case Dr. Sangwan had handled way back. So this patient came with a peripheral ulceration like lesion and a lot of thinning. It's not visible here. And all of these white areas are actually keratic plaques. But if we don't think, because we are cornea specialists, so we may not automatically think of OSSN, we might miss the diagnosis. So that's all I had, because it's a shortage of time. And I'm practicing at a new center now for the time being, after practicing for donkey's years at Heli Prasada Institute. And this is my team over there who have helped me put together this presentation. Thank you very much. Thank you.
Thank you, Somasheila. Please come join us here. Thank you very much, Somasheila. Myself and Dr. Somasheila have been in LVP for almost 20 years. And recently I moved to Delhi in about 5 years back. And Somasheila is an authentic immunologist. She did a fellowship with Dr. Narsingh Rao way back in 2000 or 2001.